Well, good afternoon, everyone. I want to extend my thank you to the Summer Institute Planning Committee for inviting us to share today. As the introduction said, I work as a nurse consultant in the Early Start and Health Services section at the Department of Developmental Services, and I'll refer to our department as DDS. I will begin our presentation with some information about the delivery of services and eligibility and referral process for Early Start. Now, some of you have a lot of experience with referrals. However, I don't want to miss this opportunity to share this information for those of you who may not be as familiar. The Individuals with Disabilities Education Act, we have no financial relationships to disclose. All right, and getting on with the Individuals with Disabilities Education Act, or IDEA, Part C, governs early intervention programs for infants and toddlers with delays, disabilities, or at high risk for disabilities. California's Part C program, called Early Start, and DDS, is the designated lead agency responsible for the administration and coordination of Early Start. The coordination of Early Start involves multiple agencies who deliver early intervention services. DDS contracts with 21 regional centers throughout the state who are nonprofit, board-run agencies who are responsible to provide and coordinate services and supports for individuals with developmental disabilities. This not only includes children birth to 3 for Early Start, but also provides this service for all qualifying individuals from birth until death. Early Start services provided by the regional centers are actually provided by service providers who are vendors for the regional center. California's local educational agencies provide Early Start services for infants and toddlers with solely low incidence disabilities, which include deaf and hard of hearing, blind and low vision, and severe orthopedic disabilities. Early intervention services may be arranged by regional centers or LEAs if a child has multiple disabilities. Some LEAs do not provide services jointly with the regional centers, so in this case, the regional center would be the primary agency for the children with a low incidence disability, along with other delays. Additionally, California funds 47 family resource centers to provide additional parent-to-parent support for families participating in Early Start. These centers work collaboratively with the regional centers and may provide information and referrals to community resources, information on specific disabilities, and a variety of parent support activities. Reasons for concern for infants and toddlers at risk for developmental disabilities or delays may begin before the child is born, at the time of birth, or any time during the first 3 years and beyond. Early Start services may begin at any time after the child is born up until the age of 3 years. This slide shows some of the many ways a child may be identified for a referral to Early Start. The first, through prenatal genetic testing. The second, through circumstances of birth, such as prematurity with complications, prenatal substance exposure, or other risk factors. And the third, developmental concerns of parents, healthcare providers, family members, child care, or anyone close to the family. Many of these concerns may be brought to our attention by screening and followed by referral to Early Start. The referral begins with a phone call to a regional center or local educational agency. This referral also begins the Early Start timeline to evaluate, determine eligibility, and develop a plan for the child and family if the child is eligible. All of these components are expected to happen within 45 days. Following parent consent, eligibility is determined when the child is evaluated in all developmental domains, including vision and hearing. This includes the utilization of standardized tools, a review of medical records, a parent interview, direct observations of the child by qualified personnel. The child may qualify for Early Start services in 3 areas. Some children may qualify because after they are evaluated, it is determined that they have a 33% or more delay in 1 or more areas of development. Other children may qualify due to an established risk condition that is known to have harmful developmental consequences. Examples of some of these are some chromosome variations such as Down syndrome, sensory impairments such as blindness or deafness, sensory inborn errors of metabolism, or congenital infections. In order for an infant or toddler to qualify under the at high risk category, the child must have 2 qualifying biomedical factors, or they may have a parent with a developmental delay. The referral starts with a concern for a child's development and may come from a variety of sources, as I have already mentioned. Anyone can call the regional center or LEA to start the referral, but it is best to include the parents, since they will be an important part of the process for evaluation and beyond. The referral should be made within 7 days of identifying the child. This 800 number is our baby line, and it can be called to find the correct location for the referral, either the LEA or the regional center. It is best to have an established relationship with your local agencies to understand their individual referral process. Information on regional centers may also be found at the DDS website that I have listed on this slide. Anyone with a concern can refer to Early Start. The parent will be contacted. The timeline for follow-up begins on the date of the referral. The Individualized Family Service Plan, and we also call this the IFSP. Once the child has completed the evaluation and is determined to be eligible for Early Start services, there may be additional assessments to be completed, and the IFSP process will begin. The IFSP meeting includes an interdisciplinary team with parents, family included as team members, and will occur no more than 45 days after the initial referral date. The process at the IFSP meeting will guide the development of the plan and monitor progress for the child and family during Early Start participation. Information that has been gathered will be reviewed, and specific obtainable goals will be developed for the child and family. These goals are called outcomes, and they shape the support that the family will receive throughout Early Start. All services that are provided are directly tied to achieving the outcomes that the team has identified as being important to the family and child. Future meetings will be built around evaluating progress toward those outcomes and updating the plan to continue to address developmental outcomes that are a priority for the family. Services identified in the IFSP may be provided by a number of different agencies. Regional centers will vendor with service providers. The regional center is the payer of last resort. There are federal and state requirements to exhaust other funding sources. All services must begin 45 days, start with 45 days of the initial IFSP, so exploring other funding sources must not delay service provision. Other funding sources may include generic resources such as mommy and baby classes, playgroups, or other community activities. They may also include health insurance, including Medi-Cal, who may offer speech therapy or ABA services. There are provisions in statute for regional centers to pay insurance co-payments under specific financial criteria. Services are also provided through local educational agencies. And I'm going to pass the microphone to Sharon to continue.
So you might ask, what is the State Systemic Improvement Plan? We call it the SSIP, okay? So I'm going to talk about it. I'm going to use that acronym from now on. And it is a federal requirement. It's something that the Office of Special Education Programs has asked us to do. It is a multi-year, achievable, and hopefully self-sustainable plan. And so, and the federal government is basically, saying the key word is achievable, meaning that they've let states determine what their plan is going to be based on their resources and their infrastructure, okay? So, but they did give us a few things that they wanted us to really focus on in our plan. They wanted us, our plan, to include increasing the capacity of early intervention programs to implement and sustain evidence-based practices, okay? They also felt, of course, it was very important that we looked at our current system and our infrastructure and made changes to that infrastructure if we could to make it better for our provision of services. And finally, they, of course, wanted us to be able to improve outcomes for children with disabilities and their families, okay? And as I said, it is a federal requirement. It is part of our annual performance report that we report to the the federal government every year, and we provide them with our outcome measures, okay? So in order to develop the SIP, we are doing that in 3 phases, and the federal government has asked us to do that in 3 phases. Phase 1 has already occurred. That's our analysis phase, and the first thing we did to be able to develop our plan was we convened a state systemic SSIP task force work group. They were a work group of early intervention stakeholders, regional centers, providers, family resource centers, and families and parents. Okay. So, and that work group worked very hard in the first year, in 2013 and 2014, to develop kind of a structure of our plan. We had to identify the outcome measure we wanted to focus on, because we had to do that to show that we were going to improve on something in that year. We had to talk about our infrastructure and, how this plan would work, how it would work. And we needed to also identify improvement strategies that we wanted to make to hopefully make our outcome measures successful, okay? For our second phase, which occurred in 2014, it was just we put more meat on the plan, basically. The SSIP task force work group met. We did more development. We did a lot more work on specific activities we wanted to target. And also we needed to find a way how to evaluate our plan, because that's also a federal requirement. We have to show some progress in our plan. And the last phase 3 is over several years, and it's really just reporting back to the federal government on how we're doing on our SSIP, how our plan is going, results of ongoing evaluation, whether we want to make changes in it, and so forth. So that's kind of the long-range plan for the SIP. So part of the phase 1 is, I said we had to determine what was the outcome measure we wanted to focus on. And that's what we call the SIMMER. So, and that's the state identified measurable result, okay? So our SIMMER, this SSIP task force work group determined what they wanted to focus on, and that is basically, and I'll read it to you, increase the percentage of infants and toddlers with disabilities in California who will substantially increase their rate of growth in positive social emotional skills, including social relationships, by the time they exit the early intervention program. Okay? So we're focusing on social emotional development skills in infants and toddlers. Okay? So you might ask why the SSIP task force work group wanted to focus on social emotional development. There are lots of things we could have chosen to do. But some of the key reasons were that we took a look at our data and our outcomes, and we realized we could improve on this area. Okay, so we thought, okay, let's choose something we can improve on and see if we can make a change. We also know through research that social emotional development is the basis for other developmental domains. It also leads to increased positive future outcomes, creates it helps children's later health, success, and overall quality of life. And it shows that social emotional competence is one of the 5 protective factors that help children and families thrive, okay? So we know that, just building social emotional skills and development skills in children we have to engage the family. They really are the key. The parent-child relationship is the key to social emotional development. So part of our plan is really focusing on targeting families and including them in some of these activities. We also know that families with children with special needs require some extra help to build that relationship sometimes. And that family-based intervention services are also in social emotional development, help children to be more easily comforted. They pay more attention to what is going on in their surroundings. They regulate their emotions better. They learn they can influence others through their actions, and they develop more secure attachments to their parents or other caregivers. So the next thing we had to do was, what activities were we going to do to see if we could, we could implement in the plan to see if we could move the needle on our social emotional outcomes and if we could improve that in California. So we decided to kind of target 3 strands of action. The first strand we wanted to look at was parent-provider education. And so we developed a tagline, basically, and that is, "Take a minute, relationships matter." We basically wanted to have a flyer that was related to that, a 2-page flyer and a video for parents and providers that they could click on a website and read, look at. We could distribute the flyers, however, and get the word out. So, and basically these 2 items or resources have information on social emotional development. It's geared towards families, so it's at a level that is easy to understand. It's not very scientific, okay, but it has some of those really good tips for them, for families. And then we decided to also have a checklist for family-centered practices for providers, because we also realized that they needed to, when they serve their families, provided services, that they should be using family-centered practices when they engage them, okay? So we also have that checklist as well. So that's part of our Take a Minute, Relationships Matter campaign. And you'll be seeing that soon as things come out. Our second strand was to target professional development. We wanted to have a place where everybody could go to, all early intervention providers, families, and parents could go to kind of see all of the research on social emotional development, see the Take a Minute, Relationships Matter brochure and video, just a common place where they could go. One place we could give them a link and they'd have it right there. And also for professionals to go to have discussions with each other, do some chat rooms stuff, share resources, and that sort of thing. So that's what we're calling our community of practice. We have that up and running as well. That is on our Early Start neighborhood. It's a website, basically. You can get on there. I'll give you the link later. You can go on there, click on SSIP resources. You don't have to sign up for anything, and everything is just there, all of our resources and additional information as well, okay? So, and also the next thing that we're very excited about is that we modified some existing training that we had on social emotional development. We made it shorter and made it more available to participants. We have a great professional development training for Early Start already, but what we were finding was that it was taking some time for people to go through the course. It's a facilitated course, and it took several weeks to get through. So we modified this training, and it's on our Early Start neighborhood website as well. You have to sign up for it, but it's free. You can use it with groups. You can use it yourself. You'll get a certificate of completion at the end. And you do have to take a pre and post test though, so sorry. Okay, so that's something we also are very excited for professionals, because I think they could really use that resource. Okay, and the last strand was interagency collaboration. So we knew that it was going to be key to get all of our partners involved, early intervention partners involved in making this plan work statewide. So we decided to partner up with our Interagency Coordinating Council on Early Intervention, it's our ICC. They are a group of professionals interested in early intervention. Some of them are government appointees, others are from family resources, community representatives, professionals, doctors, we have a wide range of representation on the ICC. They decided that they would help us in our SSIP. They are also putting together a resource guide on statewide initiatives that address social emotional development so that regional centers and other providers and professionals can research those initiatives. And they are also putting an evidence-based infant-toddler social emotional assessment guidelines, because we know how important assessment is in the early intervention world. So those are also two resources that we'll have very soon. So the next thing we had to ask ourselves is how we were going to do this statewide. California is a big state. We've got 21 regional centers, and they all have local catchment areas, and they're all different by regions. They serve different populations. Some are urban, some are rural, and so we decided to break it down into 3 phases, to break out the implementation statewide in 3 phases. The first, and in each phase, we will have an implementation cohort. So, and in that cohort, we're going to have anywhere up to 7 regional centers and their local implementation teams implementing the plan. So regional centers are the lead, to develop the plan, and then they should engage, and we want them to engage their partners in early intervention at the local level to kind of engage them in their plan, in our plan. So we're hoping that they'll have representatives from family resource centers, LEAs, other community partners, First 5, Head Start, and so forth. So that's what's happening now, because we do have cohort number 1 that is already starting to implement. And then this just shows, again, that, we have cohort number 1. We have 5 regional centers that volunteered to be the first cohort. And I want to say they're not receiving any additional funding because we did not receive any federal funding for our plan. But they still volunteered and thought this was a really great, something they needed to work on and improve for their population. So those regional centers are San Diego Regional Center, Far Northern Regional Center, Valley Mountain Regional Center, East LA Regional Center, and I'm missing one. Did I get 5? Jeez. East LA, San Diego, sorry. Yeah, and I think Far Northern. Oh, Alta. Sorry, I left out Alta. Yeah. Local. How could I do that? So, in Alta California Regional Center are participating. And then when we go on to 2017, we'll have another cohort. And then finally, the final regional centers will implement. Okay? So, and we are providing all of these regional centers with one-on-one technical assistance. So we have DDS, my staff, one staff person works with each regional center to help develop their plans. We're providing them with guidance. We want them to develop their plans, though, with some guidance, and we have to follow federal guidelines and so forth. But we want them to do that because, we want them to use their local resources. We want them to use their strengths, and we can help them with some of the barriers that they might have, to implementing this plan. We also have our West Ed partners. I don't want to leave them out. Our West Ed contract partners who have helped us with some of the resources that we've provided, and they provide technical assistance as well. So you're all kind of wondering, how can you get involved in this, right? Anyway, because it will be coming to your region very soon, somehow. Hopefully you'll hear about it. But, some of the interagency opportunities include, the Interagency Coordinating Council for Early Intervention. Anybody can apply for an appointment by the governor. It's online. It's on our DDS website. You can even be a community representative on that council. And, on that council, there's also public comment and participation as well, okay? And ICC, like I said, is very involved in the SIP and helping us with this. Then there's the regional center cohorts, so, and local implementation teams. You can contact the local cohort number 1 regional centers if you're in that area. We'll have SIP materials on our DDS website as well. It's under construction right now, but we'll have that. And we will also have the contact numbers for the regional centers that are in cohort number 1 and additional information. And then there's also the community of practice. Anybody can get on the community of practice. They can get on to learn more about social emotional development. They can learn about resources, who to contact, and anyone can access the course on social emotional development. And that's free, and it's a great course. I mean, what can I say? This is the link to the Early Start Neighborhood. And I was going to try to show it to you, but I don't think we have time. So I don't know if you want to take it down or whatever, or we can, you can contact us and we'll give it to you. But it's available now, and it's there for the public, okay, for everybody. And what do we want to see when this is all said and done? We would really like to see we want to see the regional centers and local implementation teams really sustain this work, even after it's all over. So we don't want to call it a pilot because, we really want it to continue somehow. So we want to see, families receive the education and support that they can, they need to fully engage in their child's social development through that parent-child relationship. We want to see service providers consistently implement evidence-based practices in social emotional development to support the parent-child relationship. And we want to give service coordinators tools to empower families and support that parent-child's relationship. And mostly, we want to see early start infant and toddlers increase their rate of growth in social and emotional development. And we'll see if our plan works. We'll be gathering evaluation data and other data within the next couple of years. So if you hear about it and you hear about Take a Minute Relationships Matter, you know that that's our state systemic improvement plan. And if you want more information, you can contact us. So thank you very much.
Hi, I'm Kristen Rogers. I'm in the California Department of Public Health, and I oversee a lot of programs, one being the California Home Visiting Program. So I'm going to go through that with you, and I guess we're doing questions later, is that right? Yeah, okay. So the California Home Visiting Program came out of the ACA in 2010. It's an amendment to the Social Security Act, and it it's called the Maternal, Infant, and Early Childhood Home Visiting Program, so better known as MIECHV across the country. It's in every state and every territory. There was $1.5 billion set aside for 5 years. We've been told they're moving into this over like $1 billion now per year, but I don't think that's going to happen, but that's the proposal. So again, 50 states, DC, 5 territories, they're all formula grants, so they're based on poverty levels of women that are giving birth. We have tribal MIECHV. We have 3 tribal MIECHVs in our state. There's research and evaluation that's going on. It's 3% set aside. It's an independent evaluation that is going on, and I believe is just finished. There's 17, now there are 17 federally approved home visiting models. When we began, there were only 8, so we're slowly getting more and more across the country. The goals of MIECHV are to improve maternal and child health, to prevent child abuse and neglect, encourage positive parenting, and promote child development and school readiness. And these are the federal priorities here: pregnant women under age 21, families in at-risk communities, low-income families, families with a history of child abuse or neglect, families with a history of substance abuse, families that are users of tobacco in the home, families with children who have low student achievement, families and children with developmental delays or disabilities. So again, these are the targeted federal priorities. So back in 2011, the governor designated the California Department of Public Health as to oversee and administer the MIECHV program. It's now which is where I am, in the Maternal, Child, and Adolescent Health Division. So what is home visiting? And I'm not sure, do you guys raise your hands? Do you guys know what home visiting is? Not everyone, right? Some, most, okay. So it pairs at-risk, new and expectant parents with trained professionals, and those can be either social workers, paraprofessionals, nurses, it can be RNs, LVNs, and they provide parental skill building, resources, and support. Home visits are typically once per week at the beginning, especially during pregnancy and the first 6 months of the baby's life. And then depending on the model, it'll go from 2 to 5 years, and they'll either do every week, every other week, it just depends on risk. The goals of home visiting in California are to assist parents in having a healthy pregnancy and delivery and in becoming knowledgeable and responsible parents. So these are some of the evidence-based outcomes. There's a lot of research that's come out on home visiting, and I'm just throwing through a few of them in here. So the research has shown that these programs, they increase or improve prenatal care visits, so the amount of prenatal care visits that are conducted, breastfeeding rates, parental capacity and efficacy, positive parenting behaviors, immunization rates, infant, child, and maternal health, the identification of early developmental delays, child language development, and school readiness. More evidence, lower rates of pregnancy-induced hypertension, smoking and complications during pregnancy, low birth weight and preterm births, lower rates of maternal depression, childhood injuries, and death, lower rates of emergency department visits by both mother and child, lower rates of second pregnancies and longer interbirth intervals, behavioral impairments due to the use of alcohol and drugs, child maltreatment, Medicaid use, and then the use of TANF and food stamps. So this is just a couple of things, ROI. These were done by Nurse Family Partnership. I'll talk about the two models, but they've done most of the research around ROI. So evidence has shown that home visiting programs are shown to decrease the incidence of low birth weight infants among home visiting participants by nearly half. And the estimate is to avoid $28,000 to $40,000 in health care and other costs. And then for every public dollars invested, there's a lot of different ROIs on this, but this one that Nurse Family Partnership did said that for every public health dollar invested, the savings of $2.88, and among high-risk clients, the saving increases to $5.70 per dollar spent. So we measure all the, these are the federal benchmarks. So there's 35 constructs. So there's 35 ways of measuring these 6 benchmarks. So the 6 benchmarks, and we have to show improvement over the first 3 years, then the first 4 years, and then the first 5 years. So we're on the 5th year right now. Improvement in maternal and newborn health. Again, I think there's like 8 constructs within that. Prevention of child injuries, child abuse, neglect, maltreatment, and reduction of emergency department visits, improvement in school readiness and achievement, reduction in domestic violence, increase in family economic self-sufficiency, and education is also within that construct or benchmark, increase in the coordination and referrals to community resources, social services, and support. And I think this is the main, this last one is the main thing that all the home visitors do, for those of you especially who understand this and know about it. They do tons and tons of coordination and referrals. And so how the California home visiting program works is, so at the local level, the funding for our sites, and I'll show you a map, we have 26 sites in 24 counties throughout California, and they're administered right out of the departments of public health at the local level. There's 4 that actually have CBOs attached to them, so it's a pass-through, but the rest of them are all come right out of the departments of public health. Then there's a few other funding sources. A very large funding source, as you probably all know, is First 5. At the local level, there are First 5 commissions that really do put a lot of money into home visiting, but it's locally driven, it's not state driven. And we work very closely with them also, thank goodness. Then there's also local program funding. So the local MCA, Maternal, Child, and Adolescent Health, directors in each of the counties will braid funding to get more home visitors. So then the two models that were chosen in California back in 2010 are Healthy Families America and Nurse Family Partnership. So Healthy Families America are, so they emphasize it's for families at risk for adverse childhood experiences. And these are, I mean, this is true about pretty much all the models, but they have specific criteria. But anyway, so they choose for families who are at risk and have history of trauma, intimate partner violence, mental health, or substance abuse issues. Home visitors tend to be paraprofessionals. They do have nurses as well. And paraprofessionals can mean anything from bachelor's, master's, or even just paraprofessional in the community. We have quite a few home visitors now that used to be clients, which is really interesting, that have gone on and gotten bachelor's degrees and are now in Healthy Families America. So flexible curriculum designed to empower parents, enrollment prenatally or soon after birth. And that's our requirement. Healthy Families America, you can enroll at any time if you have children. But because we have to monitor the federal benchmarks, we have to have them in earlier. The services begin intensively and continue up to 3 to 5 years after birth. The intensity adjusts to client need over time. And then Nurse Family Partnership, it's the only criteria, you have to be a first-time mother, living in poverty, enrolled during pregnancy. Services provided until their babies reach 2 years of age, and at 2 years they drop out. Home visitors, and when I say drop out, there's a lot of transition planning, but there's no more NFP after the baby's 2. Home visitors are always public health nurses. These are one-on-one home visits, weekly during pregnancy, bi-weekly postpartum. Again, similar, all the models are similar in that sense. Rigorous standards for enrollment and staffing and program fidelity and caseload. And so how we chose the sites in California, there was a comprehensive needs assessment done. There was a very comprehensive RSI done as well, and the indicators were first-time mothers on Medi-Cal and mothers less than 25 years and families below 85% of the federal poverty level. And we've found that every single county now has this. So before, believe it or not, 5 years ago, it wasn't, sadly, every county is now, could have a home visiting program under these criteria. So here's a map of our sites, and you can see the darker purple. Those are the NFP sites, and we're predominantly NFP. I think there's 18 sites, and there's 8 HFA sites, and a few of our sites have both, which is great. So it's all the way to the Oregon border, down to the Mexico border, and down in San Diego, especially Imperial, there are a lot of women that cross the border to get health care, and I'm sure you know about that as well, which is great. It works really great, and the home visitors can easily take care of that as well. They don't cross the border, but they help the women, regardless if they cross the border or not. So some of the components of our program is that we provide programmatic oversight and monitoring. We have a statewide data system that has over 1,000 variables in it. There's a lot of research scientists and epidemiologists that work for me, and then there's a lot of program specialists that also work for me. So we monitor and report legislatively those benchmarks I showed you earlier. We provide data, actually it's live data to the locals so that they can monitor at any point in time. We have a rigorous continuous quality improvement that's data-driven, and systems integration evaluation. That means that one of the mandates that the feds have handed down is that we're supposed to be changing how systems operate at the local level. So we work really hard at that, and we have a rigorous evaluation by the research scientists. So our statewide data system is called, you don't need to know all this, but efforts to outcomes, and it's a live real-time database. It tracks client-level activity, and we also can look at staffing, attrition, retention, and federal benchmarks. We have a really hard time in the Central Valley with staffing of Nurse Family Partnership. The nurses, they come and go really rapidly. They can get a lot more money at the hospitals or the prisons. We have a really hard time in, say, Del Norte County, where Pelican Bay is. So it's an interesting, we're sort of coming to find out that nurse-family partnership works best in large cities. And these other paraprofessional home visiting programs work much better in our rural counties, especially the Central Valley. So here's, I think I'm almost at the end. Do I have much time left? No, she's, it's all right. So, excuse me, we have, this is our recent data. This is a very expensive program, so you'll notice we don't have a lot of participants. So we've served over almost 6,000 families now. And we're currently around 2,200, and the total capacity is 23. And as you can see, if you just look down quickly, the ethnic breakdown, Hispanic is the majority of our women. And going down to race, it's white. I also oversee what's called Black Infant Health for the state of California. And so there's a lot of crossover, and I can talk about that later if someone's interested, but there's a lot of crossover with home visiting and the Black Infant Health programs. Age ranges, we even have had a 10-year-old, believe it or not, giving birth, and then all the way up to 44, and looks like the majority is between 22 to 29, and then 50% and under, so are under the federal poverty line. And then lastly, there's the vast majority of women are either uninsured or on Medi-Cal. Education, they tend to be, we do have the majority of some college training, so high school diplomas. Then the vast majority, again, are single, never married. And probably all this is pretty obvious, the vast majority also unemployed. So CQI process, just quickly, it's data-driven. There's this constant loop going on with the state, and that's, again, we have to monitor the federal benchmarks and all the data. And then the systems integration, I talked about that already, the evaluation that we do. We really look at what's in the red, which is how has the MIECHV funding and MIECHV programs affected early childhood systems of services. So we're really seeing some interesting work being done at the local level. I guess I thought I was almost done, sorry. So we have a state, actually, Elise sits on this. We have a state interagency team, home visiting work group, and these are all the departments that are coming together. We do it quarterly. I chair that. And it's a really exciting group. We've done some amazing work. Like, for instance, we've had HUD come, and we've been able to get shelter beds for women that are homeless and pregnant that are in home visiting. San Francisco is a great example of their NFP program. We've done things like high school credits, where we have the first home visiting program in a school district. It's LA County, and so San Diego and LA and a few other of our counties actually are giving high school credit to women in the program. So that's it. References. That's who I am. Questions later.
I'm Theresa Costa Johansen from the California Department of Education. And I have a tendency to talk very fast, and I tell a lot of stories, so I'm just going to put that out there up front. And the title is Department of Education, Special Education Division for the UC Davis Mind Institute. But I'm going to really call this the wait what talk. Any of you have teenagers at home? You know what I mean when I say the wait what? So my son just turned 18. He's going to be a senior this year. And, kind of a typical conversation is, hey, babe, today we got to do this and this and this, so you need to get this and this and this done, and then I know you have to work, and I know you've got football practice, and you've got this meeting. And then it's, wait, what? So, yeah, that's at my house every day, and I'm going to tell you about kind of my wait, what journey. And I'm also going to tell you a little bit about, hopefully, how I'm addressing some of that wait, what confusion that I have. So, background and context for me, my background is general education. I am certain that somewhere in my family history there's a chromosome that codes for education, because both of my parents are retired teachers. I have grandparents, great aunts, uncles, cousins, once, twice, and 3 times removed that have all been in the field of education. So I literally have lived my entire life on a school calendar, always, my whole life. So I came to the California Department of Education with a very strong background in education. And I pretty much thought I knew how schools worked. But my background was not special education, it was general education. So one of the first things they did when I got there is I was hired into what's called a monitoring unit in the special ed division. So my job was to be part of a team that goes and looks at school districts to ensure whether or not they are compliant with IDEA and special education laws. So I showed up like a bright, shiny penny on my first day of work, and my new manager said, you know, I've looked at your resume and I looked at your background, and I'm going to assign you to some districts that you're going to be responsible for. And I was so excited. And I said, which ones? And she said, you get Los Angeles Unified, Los Angeles County Office of Education, who happens to have juvenile court schools and a charter school, SELPA, so they have 2 SELPAs. You get Pomona, you get Pasadena, and you get the West San Gabriel Valley SELPA. And I said, wait, what? Do you know? I said, where I live. She said, yeah, I live in Butte County. How many people know where Butte County is? Okay, a few, all right. The biggest school district I have ever worked in, 5,000 students. Total, if everyone showed up on the same day. And you're going to give me Los Angeles Unified? She said, no problem, go for it. So I did. How do I advance this? What's the secret here? Did you just use this?
No, I did this. There, this one.
Ah,
yeah, this one.
okay, that one. What I'm going to talk about today is sort of a very broad overview of how these different initiatives and plans work together. And I thought this quote was a good representation of what we've been doing at the State Department of Education in terms of how we look at accountability and these different mandates. So my second wait what moment happened to me when what we call our interim director right now, Chris Druin, came to me and he said, hey, Theresa, there's this thing called UC Davis Mind Institute, and they're doing a summer institute, and I'd like you to go speak. Okay, I can do that. I said, what would you like me to speak about? And he said, well, how about early childhood education? Wait, what? Chris, I taught middle school. I taught high school. I've been a middle school and a high school administrator. I don't know early childhood education. He goes, well, they're really going to be talking about initiatives and changes at the state level, so you can talk about that. Okay, I can talk about that. But if you're expecting me to talk about interventions for infants and toddlers, not my specialty. So that was another wait what moment for me. My third one came when I went to the State Department again and actually started working there. And I shared with you that I was assigned to a compliance unit. And one day I wanted to know what a different unit did, because we have a bunch of little like subgroups at the State Department. And so I said, can I just go over there and talk to the people in the data unit? Because they sit around the corner, and I just had a question, can I go talk to them? No. Not only are they in the same building as me, they're on the same floor as me. No, you're not supposed to go talk to them. Wait, what? So then another day I had a question about English language learners. English language learner division is just across the hallway. Can I go talk to the EL people? No. Wait, what? So I'm kind of stubborn, and I insisted and persisted and actually started asking a lot of questions and learning a lot of things that really were not inside my official job description, but are serving me well in my new position, because our interim director, Chris Druin, hired me to be the director of the policy, or the manager of the Policy and Program Services unit. And so what he has put me involved in now are all of these accountability initiatives that are going on not only at the federal level, but at the state level, and actually internal at the California Department of Education. And although these are all critically important, and the first three are mandated by law, truly this last one, Blueprint 2.0, which is initiative by our state superintendent, in many ways, that one is the most crucial for me as an employee of the State Department of Education, because what that tells me now is not only do you get to talk to people in different units, but you have to talk to people in different units. That is the expectation. Different units, different divisions, different branches. We have a fascinating org chart at CDE, but the initiative that is driving these internal changes is that Blueprint 2.0. So for the first time ever at the state level, we have people involved in special education, the state systemic improvement plan, people involved in funding and finance, the local control accountability plan, and people involved in federal compliance, the Every Student Succeeds Act, talking to each other, asking questions. I know, she's smiling. Asking questions, and even more important, listening. Special education for the first time has a seat at the table for every one of these initiatives. Unheard of. So you heard the first two speakers, you heard Sharon and, I forget, Elise, who talked about the state systemic improvement plan? It was Sharon, okay. So you heard Sharon talk about it in terms of for infants and toddlers. There's also a state systemic improvement plan, or what we call as SSIP, for school age. I've been a part of those conversations. 30% of my time as the manager of my unit is devoted to the local control funding formula support team. So every other week I go to meetings around funding, and I sit at that table and I say, why aren't students with disabilities a part of those priority groups? And I will share some of those slides with you that I've shared and Kristen Wright talked about as well. In addition, I'm sitting on a small subcommittee that is evaluating the plan, the ESSA accountability plan, as it's being written, and it's literally being written as we speak for the state of California. I go to those meetings together with colleagues and say, where are students with disabilities taken into consideration in the development of these rules and regulations? And I've been a part of the Whole Child Blueprint 2.0 initiative. Together, it's not just me that's doing this, but the key point for me, the key takeaway, is that for the first time, we're all sitting and talking and close to speaking the same language. So we're talking OSEP, the Office of Special Education Programs, we're talking CDE, we're talking the Governor's Office, the legislature, finance and budgets, and the U.S. Department of Education. Unprecedented. I kind of go, wait, what? Like, shouldn't we have been doing this all along? But we didn't. I've been to school districts. I won't name them. But I've been to school districts where the special education department was in a portable trailer, portable building, you know, way, way, way in the back of the district office campus or the district office site, and the district office was up in the front. I've been to school districts where I was speaking to the special education director, and I wanted to know how they interfaced with general education, and she said, just on the other side of the hall is general ed curriculum and student services, and even though they're just, see that door right there, they're right over there, we never talk. Wait, what? Just to give you an example again within CDE, these are some of the different collaboration initiatives that are taking place. So again, for the first time, the Special Ed Division, the ESSA State Plan Office, the Assessment Division, the Improvement and Accountability Division, the EL Division, Curriculum Frameworks, Professional Learning, and Coordinated Student Support were all talking and meeting together. Unprecedented. Earlier this morning, you heard Kristen Wright and I think it was Maureen in the Special Education Task Force refer to the populations of students in the state of California, and again, why it matters. So this gives you a breakdown of the different disability categories and the percentage of students that fit those categories. And then here's a student subgroup and ethnic breakdown. But the point really that we've been making over and over again is, first of all, students with disabilities are students first. They're general education students first. And they oftentimes fit into what we have singled out as priority categories. So they are also socioeconomically disadvantaged. They are also English language learners. We heard some interesting stuff. If you had a chance to be in, I think it was Josh, I don't see his last name right, Hibel's presentation on significant disproportionality. They are also students that are in their foster youth. So they fit across all these categories. And when we're writing plans to define how they will be assessed and how districts and schools will be held accountable for their outcomes and how budgets and finances will be set up, they need to be part of that conversation. I know I've shared this experience previously. I'm the mother of a son who has a disability, and when we were at his IEP, I was told that he was not entitled to any additional supports and services. That this is a Title I high school district, and I was told that he was not entitled to what they call that SES, that extra supports under No Child Left Behind, because he didn't qualify. We're not in poverty. He's still a student with disabilities, and he's still a student that's not making sufficient academic progress. But their point was he fits into this category over here. He's a special education student, but he's not a Title I student, so he's not entitled to that. I know, I know. Wait, what? I know. But so I'll talk a little bit too about opportunities and challenges with this, what comes up. But part of the problem is that we put students in boxes. And when we put them in those boxes, it becomes very difficult to get them out. Some of the key components of the State Systemic Improvement Plan when it comes to K-12 have to do with a tiered approach to technical assistance, focusing on evidence-based practices, and obviously we're going to look at student engagement, student discipline, access to and instruction in the California standards, which then translates to how are they assessed? So assessment, there will be measures of assessment. There will be measures that have to do with suspensions and expulsions, and there will be measures that we're hoping will be focused on chronic absenteeism, and because those are believed to be proxies for student engagements. If students are not coming to school, that tells you something right there. So those are the key components of the K-12 State Systemic Improvement Plan. Some key components or potential accountability measures under ESSA include conditions for learning, student achievement data, obviously, graduation rates, post-school outcomes, and student engagement and school climate. So here's ESSA. Here's the federal accountability for all students. There's the state accountability for students with disabilities. Do you see any overlap? It's about time, right? So my thought, I love it when a plan or 4 or 5 plans come together. Again, for the first time, it appears as though the plans in California, at least, are starting to merge and fall in alignment with each other. I spent 15 years of my career as a school administrator. I wrote more plans in that 15-year period of time, more papers than I had to write when I did my dissertation, because you had to do your single plan for student achievement. You had to do your school accountability report card. You had to complete the consolidated application. You had to do the local education agency plan. If you had English language learners, you had a plan for English language learners. You had all kinds of plans. The direction from the state is that at this point is to make it so that these plans can align and overlap, so that schools are not going off or districts are not going off in 47 different directions, but they are layering those plans so that they benefit the students who need that extra funding or extra help, whatever it is, so they can benefit the best from the way those plans are written. That is not going to be an easy task because these plans are different in the way that they're written and submitted and reviewed at either the state level or the local level. But that is the thinking at the state Department of Ed right now, is that we've got to find some ways to consolidate and coordinate these plans. Some of the last little things I'll talk about is some of the differences between No Child Left Behind and ESSA, in addition to what I share with you is some of the opportunities and challenges. So some of the differences between those two is that the expectation is now, and you've heard other people speak about this as well, is that the majority of students with disabilities will be assessed using general education assessments. They will be participating in the Smarter Balance. You're shaking your head, but I'm just sharing. That's where we are right now. So if we're going to do that, we need to make sure that students with disabilities have access to appropriate grade level curriculum instruction. We need to make sure that they're prepared to participate in those grade level assessments, and we need to make sure and we need to be aware that that California modified assessment, that one's gone, that one's taken away. So there will still be an assessment for the severely cognitively impaired students, but the rest of the students will be participating in what we call Smarter Balance, the regular general education assessments that all students will be participating in. That means for LEAs and for the Commission on Teacher Credentialing, so first of all, curriculum selection becomes huge. You have to be able to, as a school district, you have to be able to adopt and purchase curriculum materials that meet the needs of all those students. You need to have staff that are prepared to make instructional adaptations to meet student needs. I think somebody else shared in one of their presentations earlier today. I think it was Terry Clark that was speaking from the CTC about how many teachers in our system today, and I put myself in this category, are ill-prepared to address the learning needs of the students with disabilities in their classroom. And I will just share anecdotally, the hardest ones for me as a teacher were when the special ed teacher would come to me and say, Theresa, this student has a specific learning disability, and you need to do X, Y, and Z because of X, Y, and Z. Wait, what? I was trained to be a science teacher. I taught life science. I was trained to teach biology. I was really trained to teach content, not students. And I certainly wasn't trained to teach students with disabilities or students who were struggling with reading or students who were struggling with attention issues. That's what we're putting on. That's our expectation now for those general education teachers. And you know, if you haven't taught, you might not think about how complex that is, but I'll just share with you a conversation I had with my middle daughter the other day. This is I have 3 children. Middle one's like bright little shiny star. Easy child, easy from the moment of birth, okay? Literally slept through the night the first night and every night after that. And of course, what's she gonna be? She's gonna be a teacher. She's gonna head off to Sonoma State in about 2 weeks. So she's been working in an after-school program, and she will come home and tell me about her students, and we have a lot of conversations about education. Of course, she knows where I work. And so I was telling her about some of the work we're doing with the AB 1369 dyslexia guidelines, and I was encouraging her to pursue sort of a specialization within the multiple subjects credentials. So she's always been really good at science and math, and so I said, maybe you should specialize in science and math, because that way you can get your loans forgiven and we can get them paid off earlier, or special education. She goes, no, don't want to do science, don't want to do math, don't want to do special education. Great. I said, we're doing this work around dyslexia. I said, what about, like, there's a reading pathway. You could get like a reading specialization. And without skipping a beat, she turned to me and she said, but Mama, why would I need to get like a reading specialization? Why would I need to learn more about, kids that are having a hard time learning to read? She goes, because because I'm going to teach first grade. Wait, what? I said, honey, do you realize what you teach in first grade? And she's like, oh. And I said, yeah, you're going to have students in your classroom that are going to struggle with learning how to read. It's a real handy-dandy skill for you to have as a first grade teacher. But as a teacher myself, going through my preparation program, nothing on how to teach students to learn how to read. And I have a multiple and a single, but still nothing. Teacher preparation, educational and professional development will be huge. Again, some of the differences, there will be an increased flexibility on assessment and the delivery mechanism. They will be computer-based with accommodations and modifications built in. The new system attempts to maximize the use of technology. Are you guys, who is like familiar with the Smarter Balanced stuff, if you will, Smarter Balanced assessment, okay? It's what you would call an adaptive assessment. So the idea is that accommodations and modifications are built into the way that is, there's different levels in the program itself, so that if a student needs something read to him or her, for example, there's a mechanism, and I haven't participated in this, but there's a mechanism to allow the computer to read that question to the student. So instead of having to get like an aide to read it to him or her, it's built into the system. Again, effective assessment delivery and seamless accommodations are crucial because we want tests that accurately reflect the knowledge and achievement of the student. But if those accommodations and modifications aren't done properly, then how are we going to know where that's a real true reflection of that student's achievement level? So those pieces are huge. I did read a frightening little piece of research the other day about that. There's some evidence to show that when tests are done on a computer, that the computer actually somehow interferes and causes the test score to be lower than when they're done on paper. That frightened me. And this was a study done with cadets, entry-level cadets at West Point. So just throwing that out there. Some of the differences, again, between No Child Left Behind and ESSA, I mentioned the alternate assessments for the severely cognitively impaired students. So there will be alternate assessments that are developed in addition to alternate diplomas. So that is very crucial when it comes to school and district accountability, because right now, students are able to receive what's called a certificate of a completion. But when it comes to calculating one of the accountability measures, which is graduation rate, certificates of completion count as a dropout. So think about that for a second. So the key point there is so motivation for a district, for example, to offer an alternate diploma, because now if they offer it and it meets those criteria, then it positively impacts their graduation rate, which is what you want. So again, opportunity, challenge. I will go through this very quickly. So just in terms of, as you think of kind of going back and forth, and I see a lot of puzzled looks, but just keep remembering it's all a process. It's in the works. So there's flexibility with regards to how we're going to go about implementing these plans. What they talked about in the Special Education Task Force, this notion of one system, appears to align to federal policies reflected in both ESSA and the IDEA. That's wonderful. Recent interaction with the Department of Ed seems to be that they are taking what we call a more enlightened view about how the state should or should not monitor school districts and LEAs and California's improvement initiatives. So those are all good things. Some of the things that I think are pretty amazing in terms of opportunities is for the first time ever as a state, if the assessments are good and they're valid, and those students have had access to those standards, we will have good baseline data for students with disabilities in the state of California relative to how they are performing on general education standards, which is what we want. We want to know how they're performing relative to their same age peers, right? That's huge. We will have an increased opportunity to coordinate federal resources and support students, what we call the whole child approach. And we will have an opportunity, or districts will have an opportunity, to confer that alternate diploma. I got a call the other day from a principal in Southern California, and he explained, he said, I'm a principal of a high school here, and we get in trouble all the time because we have a low graduation rate. He goes, and so here's what I need to know. He said, I house the district's mod to severe program on my campus. He said, I'm the only one on the campus. Do those scores for those, do those certificates for those mod to severe students count against my graduation rate? I didn't know the answer, so I went and talked to my friends in the data unit, the friends that I made when I talked to them when I first came to the State Department, and they showed me how the calculation is done, and my answer, my sad answer back to that principal was absolutely yes. Currently, those students count against you in your 4-year cohort graduation calculation. If we confer alternate diplomas and we do it right, they will count as having graduated. Each new opportunity presents challenges. LEAs must ensure students with disabilities get effective instruction by qualified teachers. They must receive appropriate accommodations and modifications. We got to fight that tendency to put students in boxes. We've got to quit fighting each other. The Title I people and the special ed people and the EL people need to get on the same plane. We need to start talking to each other and stop fighting over funding and resources. I've talked already about the alternate diploma and the opportunity that it affords, but again, it's got to be standards-based. It's got to meet high school graduation requirements, and it can only be conferred on students who meet that those age parameters, so it can only be conferred for students birth to 22. I haven't seen too many high school diplomas handed out to 1-year-olds, but you know, there could be an exception, but it's got to be within that age range that's covered by IDEA and FAPE.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.